How's it going, guys? We have a medium difficulty question for mixed step 1 and step 2. I am not going to make this a 19-minute clip. We'll cut to the fucking chase, not waste our time. So before we get started, please subscribe to my channel. I really appreciate it. Give the video a like, really appreciate it. Find me on Instagram at Mehlman_medical, MEHLMAN_medical. The link is down below. Find me on Telegram. Recently created a Telegram group and channel. Links are down below. Now let's start the clip. 24 hours after admission to hospital for sickle cell crisis, a 19-year-old man suddenly develops flank pain and red urine. Laboratory studies show creatinine upper end of normal at 1.2 milligrams per deciliter should be 0.7 to 1.2. Blood urea nitrogen normal at 18 milligrams per deciliter should be under 20. RBCs many in the urine. White blood cells rare, no protein in the urine. Question wants to know the most likely cause of the hematuria / what's the diagnosis. So let's just walk through the answer choices here. Choice A, ATN, acute tubular necrosis, wrong fucking answer. Now, by all means, sure, we could probably Google it, find an article from 1986 with 4 citations where they talk about sickle cell and ATN, not for USMLE, okay? It's not classically caused by sickle cell. You need to know that acute ischemia to the kidney is the highest yield cause of ATN across NBME questions, okay? Not my opinion, it's my observation on what's seen in NBME questions. So acute blood loss due to surgery, trauma, episode of ventricular fibrillation for 30 seconds where there's decreased perfusion of the kidney, that's the highest yield cause of ATN on USMLE. It's not pre-renal, okay? Acute ischemia to the kidney, ATN, as well as, of course, etiologies such as aminoglycosides, gentamicin can cause ATN, IV contrast, rhabdomyolysis, myoglobin is nephrotoxic. Wrong fucking answer. Choice B, diffuse cortical necrosis, wrong answer. I have actually never seen this as a correct answer on any NBME material. Exceedingly low yield, okay? In theory, diffuse cortical necrosis is the ischemic progression of acute tubular necrosis. The cortex, the PCT of the kidney, is most susceptible to anoxic injury, very, very high yield, because of the high concentrations / density of ATPase pumps that have high oxygen demand, okay? Very, very high yield factoid there. Wrong fucking answer. Choice C, interstitial nephropathy, wrong answer. This is going to be a classic scenario of an NSAID, beta-lactam, or cephalosporin, followed by eosinophils, white blood cells in the urine, plus or minus blood in the urine, plus or minus a rash in about 50% of patients. Clearly not the answer here. Choice D, focal segmental glomerulosclerosis, wrong answer. But high yield, you know that sickle cell plus renal issue where there's no blood in the urine equals FSGS, okay? It's nephrotic syndrome. So if we had the same vignette here, sickle crisis, and then they said no RBCs, and they said protein 2+, answer would be focal segmental glomerulosclerosis. The sickling will cause asymmetric / irregular infarcts in the kidney that could lead to parts of some glomeruli affected, FSGS. Choice E, nephrolithiasis, wrong answer. Whilst this patient does have flank pain, and yes, we could see RBCs in the urine, and that's very high yield for surgery, actually, for 2CK, that you can get microscopic RBCs in the urine. They ask that directly. It's not the best answer here, okay? It's not that it's impossible. It's just, it's not the best answer because we have renal papillary necrosis, which is buzzy when you have sickle cell plus red urine. So it's a couple factoids. I said sickle cell plus renal issue where there's no blood in the urine. That's nephrotic syndrome. That's FSGS. Well, we've got sickle cell plus red urine. That's going to be renal papillary necrosis. You can get microinfarcts to the papilla of the glomeruli, and that can lead to renal papillary necrosis, okay? So that's just a diagnosis you need to be aware of. It's on the NBME material for step 1, okay? Not my fucking opinion. I'm not trying to be fancy with this obscure diagnosis here. It's something you should be aware of. You know the deal. I'm going to continue to make more content. If you like my stuff, subscribe to my channel, and I appreciate your time. That's it.